Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
And what we're going to talk about today is the TIL trial. John Haanen was the lead author. Presented at ESMO 22 in Paris. Inge Marie Svane is the senior author, and this is in the NEJM publication. So, randomized trial of a cellular therapy in a solid tumor. So, pretty important. It'll be fun to discuss, I'm sure. But before we do, icebreaker, warm up, Sapna, which we haven't rehearsed in advance. Messi or Ronaldo?
Oh my goodness. I am not a major soccer person. I know the names.
So you'd be speculating, you'd be guessing.
Are we saying like who's the better soccer player, who's sexier? What are we saying? Who do I like with their shirt off?
Yeah, well, that's the whole point of saying Messi or Ronaldo. It's, you know, the interpretation is sort of, so you're not sure.
Not sure. Let's just say I'm a xenophile, so I like, you know, the Argentinian. I like the Spanish. I like anybody with an accent.
Yeah, Ronaldo's Portuguese for the record, but
oh, oops. Okay, good.
That's all right. But also for the record, I'm Messi. But maybe we'll have that discussion another time. Right. Okay. So I've got another question because that didn't work well enough for my liking. If you could invent a robot to help you, what would you have it to do?
Oh, that's fun.
Told you.
I mean, I used to watch the Jetsons growing up. Do you know this cartoon?
Yeah, we had that, yeah.
So Rosie was the housekeeping robot there. I wouldn't mind a Rosie. By the way, my sweet, amazing housekeeper in Houston, her name was Rose, and I'm now just putting it together. And she still texts me once a month because she's an amazing person. I wouldn't mind like a housekeeping robot. Then you have like a little bit of sort of quote unquote company in the house. But meanwhile, the house is spick and span and clean.
Yeah. So it'd be like a dog with benefits or something like that.
A dog with benefits. They did have Cosmo, I think, was their robot dog.
Yeah,
but the dog's going to make a mess, and I would rather somebody clean the mess.
Yeah, but then, you know, the other thing about the dog is that they probably want to come and sort of, you know, have a cuddle and stuff like that. So you need some sort of specialist robot, I think, that did that part of it as well. And it wasn't too kind of metallic, you know, you'd like fur or something. I don't know.
You like the softness,
yeah.
What's your robot invention?
What robot would I have?
Yeah.
I don't know. I haven't got a better idea than that. I mean, I think something where you could just, you know, get them to do all the stuff you wanted to do would be pretty cool. Maybe impersonate you or something. That
exists already, I think.
That would be quite an advanced robot, wouldn't it? It's probably doable. Right. Okay. So let's talk about this trial. I mean, I suppose one immediate. Well, I'll let you know. You go. Introduce it.
Oh, okay. Yeah. Well, I think also one thing to say about this trial is that we've had a few TIL trials published over the years. I mean, many, many, many. Steve Rosenberg published the first experience of TIL in the New England Journal of Medicine. I think that was back in 1981 or so. We can check on that. It was more of a series. But this is, you know, a randomized TIL trial to show up in the New England Journal of Medicine. Incredible. These are homegrown TIL that they've grown that, like you were saying, Inge Marie Svane is the scientific lead about generating these TIL in the Netherlands. And then they compared it to ipilimumab. So just a little bit more detail. This was a 1-to-1 trial done in the Netherlands where they took patients with metastatic melanoma and randomized them to either get TIL or ipilimumab. They could be either treatment naive or have received one line of therapy, but just not ipilimumab in that prior line of therapy. And ultimately, they ended up enrolling 168 patients, which is really remarkable. But if you look at the dates of this trial, they were really patient. I mean, it was, an 8-year, was it 8 years? It's 2016 to something. I lost track of the dates here somewhere. We can check it. But many, many years it took them to enroll this trial. But that's why we can see the results so clearly, I think. I think importantly is that this was a this was mostly pre-treated population. So most of these patients had received a prior line of therapy. It's around about 88, 89% across the entire study. And it was, a small amount had received adjuvant PD-1 therapy, but about 60%, 62% in total had received frontline anti-PD-1 therapy. And we presume that to be anti-PD-1 monotherapy because you could not have seen prior IPI to get onto this trial. And when the trial was run, it was potentially before the relatlimab clinical trial days. So the primary endpoint was it progression-free survival or was it objective response rate? I'm forgetting now. Anyway, we have both in this paper.
Yeah, I'm pretty certain that the primary endpoint's PFS.
PFS, yeah.
Yeah.
So, the takeaway here is that getting TIL after PD-1 exposure, which was what this population was, has a statistical improvement in PFS over getting IPI. It's probably also worth mentioning that the IPI, if you want to call it the control arm here, was also the control arm in the SWOG S1616 trial, which was PD-1 refractory, gets randomized to IPI or IPI plus Nivo, and the PFS tracks. The PFS in both of those studies on the IPI alone arm is very similar. It comes out right about 3 months or so. And so, in the TIL group, you're now more than double that PFS. In the SWOG S1616, same. If you took a combination, you were almost double the PFS. So it does seem like IPI after PD-1 exposure is not enough. Maybe something else to be done, as in TIL or combination. So this study was really, it certainly tells us that TIL is a viable strategy. And then I think we were all pretty struck by this response, which is table 2 in the paper. They have a very decent objective response rate to TIL therapy, again, in the mostly second line setting. And we should remember that lifileucel was mostly in the third or higher line setting. But here in the second line setting, it's, a near 50% response rate, 49% response rate. 20% of that being complete responses. So that's nice to see. And the thing about TIL is certainly, we can check what the median follow-up was in this study, but, with longer follow-up, what can happen with TIL is as those T cells stay in persistence in circulation, they might undergo what's called epitope spreading, and they might expand their TCR to recognize other parts of the melanoma. And then you can get these later responses or complete responses. So, at some point in the future, I think we would all be interested in hearing from John and Inge Marie if there is some later responses seen here, because that would be kind of presumed. And then also, what is the persistence, for these patients that had durable benefit, what is the persistence of their TIL in population? Maybe I'll stop there and see what your thoughts are on this.
Yeah, I mean, for me, in many ways, maybe the most important thing is the proof of principle here versus a standard of care in a randomized trial in solid tumor. I mean, the control arm has been criticized, for some of the reasons that you were alluding to, but nevertheless, I think at the time the trial was recruiting, it's not a completely unreasonable control arm.
Right.
Had the control arm been Ipi-Nivo, would you have seen more efficacy? Yeah, I think you would probably. But at the end of the day, this is a sort of, it's not a massive randomized trial, but it's showing that this strategy has a clear efficacy signal against the standard of care. So I think that's kind of number one. And then the other thing is this is an academic group. So yeah, it took time to recruit the study, but I think that in itself is impressive without question. I think some of the other than further follow up, some of the next questions that, we asked, not just you and I, but other people, what's the sort of regulatory position here?
Yeah.
What happens with that? And I mean, rather than sort of bandying that back and forth, I mean, we've talked about this a fair amount, and academic groups are just not set up in the same way that industry is to go after a label, because it's really resource intensive and so on and so forth. So in a way, that's a bit of a shame, but I don't think that's a reflection on the academic group. I think actually that sort of bit of a reflection on the system that we work in. And, it's all coming out, and you alluded to this as well, around about the same time that we'd seen some data, non-randomized data from Iovance with lifileucel. And I think it kind of stacks up, actually, as you were saying already, in terms of efficacy. I guess there's still loads of questions that are out there. For example, if you gave this type of strategy or with an anti-PD-1, what would that look like? And so on and so forth. So what about something on tox, maybe? There's the tox table. I know this because when I'm doing a talk, I get the tox table from NEJM from this paper, and I can't really fit it on one slide. And then I have to fit it across two slides, and then it's kind of difficult to talk about, which makes it sound awful. Because my take on the tox is it's all sort of stuff that we knew about already and was predictable. But what do you think?
Well, I think the problem with TIL therapy is it has multiple components to it. It has a chemotherapy component. It has the cell therapy infusion day, and then it has interleukin-2. So are we talking about the tox of any of those? The tox just with the immunotherapy part of it? Obviously chemotherapy has tox. It has expected non-myeloablative tox. And so you're going to expect a transient drop in your counts. That's what we need it to do in order to make space for these lymphocytes. Similarly, when that's happening, you're going to get things like hypophosphatemia. So if you look at table 3, you see hypophosphatemia across the TIL group in all the phases of treatment, but not in the ipilimumab. But it's transient. It's a very transient move. I don't see anything that really catches my attention in the talks, but I think it's easy for me to say. I think if you're at a place that gives TIL or has given TIL, these are sort of those routine transient side effects that you're used to. You don't tend to see long lasting side effects from the short half-life of interleukin-2 or the short half-life of the chemotherapy. So I don't see anything that sort of catches my attention. Did I miss something in this talks table here?
No, I don't think so. And I always say, and when you're doing a talk or something like that, people look at you and it kind of looks a bit scary sometimes, all of this stuff. But I think the point you just made, let's say in this situation, you're comparing it with IPI. So we all know what the tox from IPI is. And then you've got this multi-component treatment, basically, all of which chemo, interleukin-2, the treatment itself, have their own components. So it's actually a classic case of apples and pears. I don't know if that's a US expression or not. And then so it kind of makes it look a lot worse than it is. And I think I'd say the same thing about any type of strategy similar to this, lifileucel, for example. We know that the patient, it's pretty intensive treatment. The patient comes into hospital, they're an inpatient. In terms of, measuring toxicity, especially laboratory, it's just ticking a lot of different boxes. But at the end of the day, it's transient. Not many patients become really sick. And even if they do become really sick with high-dose IL-2, it's usually the kind of thing that can be turned around quite quickly, actually. So maybe there's, go on.
You can also get, I remember this just from our high-dose IL-2 standalone days, you can also get diarrhea from high-dose IL-2. When those patients say, I haven't had a bowel movement, we tend not to want to assist them because they can turn into a diarrhea. But it's a different diarrhea than, say, colitis from IPI. This is not typically an influx of neutrophils and then, an immune-mediated diarrhea so much as it is just cytokine-mediated. So, you can also say, oh, look at these diarrhea rates and things, but it is apples to pears or apples to oranges, as we would say here. It's there, but it's really hard to compare. I think the bottom line is it's like I'm not whelmed or overwhelmed by any of this toxicity in this trial.
So then maybe a broader question leading from this trial, which is this a strategy that could be considered in first line given the toxicity when, let's say with anti-PD-1 single agent, just for the sake of discussion, but it could be Nivo-Rela, but let's say a relatively well-tolerated first-line treatment with a fairly high level of efficacy, depending on what you believe, response rate 40-50%, something like that, that actually is very nicely going to help half the patients in the clinic. Clearly, this strategy has efficacy, but in the first-line situation, can you justify the tox and everything else, do you think, or not?
Yeah, so I mean, we really did not rehearse this, and that's funny. That was on my list to ask you or to at least have a conversation about. Obviously, this opens the door to us thinking about moving TIL earlier and earlier. This response rate gets higher as you look from lifileucel in the third and fourth line to this TIL in the second line. And the products are essentially equivocal. So then what about moving it into the first line, which gets to that point that I will often tell people when they look at a TIL trial, make sure you ask critically the duration of this benefit, because it's a lot to go through, both resources for a hospital or institution practice and for a patient to go through. It's a surgery, it's inpatient stay, which is usually around about 2 weeks, but could be longer, 3 weeks, depending on transfusion dependence and count recovery. And it's a lot to go through for, if it turns out to be a short PFS period. But if it's a long PFS or long time to next treatment, once you're done with this hospitalization, you don't really have to come back for a second round of IL-2. I think that's debatable. So then you're treatment free, and we know treatment free intervals are very, very meaningful. So what about moving this in the frontline setting? Does that get you an even longer treatment-free interval? Could you possibly approach the treatment-free interval that you see in Checkmate 067 or, the complete response rate? Are we curing more people? Now, there's a couple of caveats there because there's a surgery, a manufacturing period, and then the inpatient stay. A metastatic melanoma patient in the frontline setting may not be amenable to waiting 3 to 5 to 6 weeks for their treatment to start. And so perhaps in that situation where you're moving it in the frontline setting, you are combining it with some sort of checkpoint blockade, and the checkpoint blockade maybe goes first. And then, round about the second infusion or so, it goes with the treatment. But then there's controversy if you're an immunologist about what about all of this activated T cells that you're doing with your checkpoint inhibitor. You're keeping more activated T cells around, and hopefully more effector T cells around. You're shutting down the checkpoint. So you've got more of these effector T cells around, and then you just go on to lymphodepletion and you go and knock these T cells down. So did you just cut off your nose to spite your face, basically, one step forward, one step backwards? So that's a reasonable immunological question. And I think you and I both know that there's this somewhat controversial study going around, TILVANCE, which is lifileucel plus Pembro versus Pembro in the frontline setting. The concern there is Pembro an appropriate control in the frontline setting? I think that's more of a concern to people than is TIL an appropriate frontline therapy. I think people do think it could be an appropriate frontline. They're just not comfortable with the randomization there. The trial is designed, it's, regulatory reviewed. And so there's nothing more to say about changing that study design. Let's just, see the results when we see them. But I'm comfortable moving this earlier on. Actually, the other thing that happens is when you move this therapy earlier on, you're catching somebody in their immune system less exhausted on the spectrum, if you will. Exhausted colloquially, but also immunologically less exhausted. So.
Yeah, I think the first line discussion is actually very interesting. Choice of control arm's one thing. That's not a new issue in randomized trials, and there's regulatory aspects to that, and there's other aspects to that as well. And I think at the end of the day, as you said as well, the control arm's been chosen, the trial's now recruiting, so we're going to find out. let's say you chose a different control arm, ipi-nivo, nivo-rela. One thing you might say about choosing an ipi-nivo control arm is that that a load of those patients will end up getting treated with steroids for side effects. And in this trial design, remember, there's a crossover. So from the patient perspective, if you don't benefit from Pembro, you get to have the TILs subsequently, which I think for patients, honestly, I'm sure it's the same for you. A lot of our patients ask about this all the time. The ability to get TILs is really something they're interested in. So what I'm thinking about in that situation, let's say you've had ipi-nivo and you failed it, you're in worse shape by definition because the treatment hasn't worked. You've got a good chance of being on high dose steroids. Is that a good place to be
Right.
if you're going with TILs? Also,
Right.
if we're honest and we look at ipi-nivo and nivo-rela, where's most of the benefit coming from for those combinations? Is it from the rela or the ipi, or is it from the anti-PD-1? We know the answer to that, which is it's the anti-PD-1. And if we just sort of switch, philosophy almost to hematology and hematological malignancies for a second. So I think we think that we're potentially curing some of our patients with checkpoint inhibitors of metastatic melanoma. Do we have a problem of trying to move that bar upwards? No, I don't think we do. And if you think about the hematologists, decades of trials now, this kind of idea of trying to intensify up front, I don't necessarily think that, in a clinical trial, that's a bad idea, because if you see an upside here in excess of 20%, let's say, if you take ipi as your, 15, 20% on your upside, and I suppose I'm thinking about response rates because it's easier. If you saw an upside here of 30, 35, 40%, single agent anti-PD-1, I don't think anyone would say that wasn't a major improvement in the field. So I have to say I'm kind of comfortable enough. It's probably one of those ones where you're not going to keep everybody happy. With the trial design, and it's happening. It's, and I guess we're going to find out. Go on.
Yeah, may I say, I like what you're saying about if they had chosen a combination control arm at the point that those patients needed to cross over, they would be in worse shape. However, the way the TILVANCE trial is currently designed, if you progress on PD-1 monotherapy and you need to cross over, that is essentially the population in this John Haanen NEJM paper, which is you'd seen PD-1, presumably essentially single agent, because you really couldn't have seen prior IPI, and look at the response rate there. It's 50%. And in the TILVANCE, you'll get it with continuation of your PD-1. So could that be even more? Anyway, I think now that we're talking it through, just the way this landscape has evolved and we've seen John's paper now, I think TILVANCE actually does make a lot of sense the way it's designed, because you will be able to get the most from a PD-1 refractory population on the basis of what we see in his paper. If it's the ipi-nivos coming off of steroids, or just, we just don't know how they'll do with TIL being, I don't know. I can get my head around this design a little bit more this way, I think.
Yeah, and I think to that point as well, it's as clean a population as you can get in this refractory setting as well. Maybe we talk about this another time. But we know, all the baseline characteristics of these patients because they were randomized. You know exactly what's happened on the anti-PD-1. Yep. So it's a very tightly, cleanly defined group of patients. That's the kind of, unmet need as well in refractory disease, which we talk about a lot. And you're actually putting this, this product straight into that. So, I'm kind of comfortable with that as well, comfortable enough anyway. And so the question for me is how easy it is to recruit and to do this trial, phase 3, talking about TILVANCE 301 now, when inevitably you're expanding outside the small group of centres that to date have done cellular therapy. So John and Inge Marie's groups are an example of that. There's a few centres in the US, but beyond that, there aren't that many. There's Israel, for example, Switzerland, not many in the world. So a big question for me here is actually the feasibility of doing this, which will get answered as well. So,
I do think you're right, because it's going to be bigger catchment, I think, than the early lifileucel trials. Can I ask you? I don't know if you saw, but emailed you this letter to the editor that ended up getting submitted on this article about 3 months later. Did you see that one? It was
Not
on
sure.
sex-based differences.
Oh
So,
yeah. No, yeah, in any jam, yeah.
yeah, it's quite interesting. I just am just curious your take on it. So there was a letter to the editor from a duo out in Korea, from Seoul,
Korea,
South
yeah.
Korea, who noticed that in supplemental figure S9, and we've said this before, but when you read an article, always try to at least click through the supplemental appendix, because there's often some real meaty stuff there that just doesn't make it into the main article. And what they found was that there's a hazard ratio that's essentially inverted for men and women favoring TIL. So in men, the hazard ratio for death is 0.52 favoring TIL. And in women, it's 1.58. It's a completely inverted hazard ratio. And so there was this comment that, all the hormonal driven changes to the immune response that could happen in females, but historically we think of females doing better than males in melanoma. And then I thought John and company wrote a nice response. You probably know this as a 30-time New England Journal of Medicine author, that you only get it's an insanely short amount of word count to respond, 250 or 350. So you have to be incredibly succinct in your response. And what they said is, yes, this post hoc survival did show a benefit for TIL in men, but not in women, suggesting an interaction between sex and treatment group. However, the results of an additional stratified Cox regression analysis indicated that this interaction was not significant, P of 0.17, nor was the difference in overall survival between TIL and ipilimumab observed in women only. So that nor is a little interesting there. Nevertheless, this finding suggests that TIL in advanced melanoma may act through very different sex-specific mechanisms than treatment with immune checkpoint inhibitors. Anyway, it's, I don't know, kind of an interesting finding. What did you make of that?
I was wondering, first of all, whether the preferred description is sex-based or gender. Is this a sex issue or a gender issue?
NEJM likes the word sex, so I don't know if it's the Queen's English or not. But
King's English now, right, at the time of writing. But yeah, so there's some words they like and other ones they don't. But I won't say any more on that subject. This is interesting, and as they say, it's been bubbling away for a long time. This kind of, I'm going to call it gender-based differences in all sorts of different ways. But as they allude to in the correspondence, it's phenomenally complicated. And I actually think there might even be factors in there that aren't mentioned. So, you've got, kind of immune system, you've got hormones, you've got microbiome. But what about the actual tumors? What about the melanomas, men versus women? Okay, so if you just go back to the epidemiology of the disease, a lot of the melanomas in men might be on sun-exposed areas of the body, for example. The TMB might be higher, for example. And I just think, even in a large data set, there's so many things that you might want to control for, which to some extent we know already may predict benefit from checkpoint inhibitors or TILs, that I think it's going to be difficult to get much traction on this, is what I think. But anyway.
Did I not know that? Is that a true fact that men have a higher TMB in their melanoma than women?
No, I didn't say that. I said I was linking it to anatomical sites.
Yeah, but women are getting their melanoma on their legs, right? Or sometimes on their arms. And we think of men as like torso and scalp and whatever, but it's not a perfect rule. I would say the women's are also sun exposed. Yeah.
No, but I guess I was putting it in there as another thing in a small randomized trial without sort of having, anyway, those descriptions that could confound / influence.
Well, also, as I look at table 1 here, the age range is 26 to 74. So just presuming you've got women through many hormonal phases of their life there. Right. And so is that driven by the postmenopausal women, the pre, it's a huge question. But why maybe we should be looking at things like some of these hormonal factors. It's an easy thing to do off of a tube of blood, to potentially look at somebody's anti-Müllerian hormone to see how things are affecting their fertility versus their maybe estrogen, estradiol, progesterone. Anyway, interesting take on this. So I think there was something even, I want to say like Serene Loy presented it when we were talking about neoadjuvant at that ESMO meeting a couple of years ago about gender and hormones, but I'm missing the thread here. I can't remember what it was. But
yeah,
anyway,
I mean, my main take home has always been how complex this is, and there probably are some signals in here, but I don't think we've kind of disentangled them yet.
Yeah.
Okay, so I don't even know how long that is, but it must be over 20 minutes. So
30.
Wow. So we should call it a wrap. Important study. First randomized study, which is positive, of a cellular therapy strategy in a solid tumor. So congratulations to John and Inge Marie and their teams. Amazing piece of work, academic study. And I think a landmark, actually. And in many ways, I think a basis for a lot of things that we're going to see in the next 5 or 10 years. So, yeah, thank you.
Great. Thanks.
Okay. Fact check from the Rohan TILs versus IPI paper. So the citation, Rohan, Rohaan, first author, John Haanen, senior author with Inge Marie Svane, New England Journal of Medicine, December 2022. And then the correspondence we just talked about as well to mention was NEJM March 2023. So that's the easy part of the fact check.
Yeah.
Now you can do the difficult part.
I have a pretty easy part too. It was about dates of enrollment, just to put it into historical context. This was September 2014. So this precedes Ipi-Nivo even as a regimen, as an approved regimen, right? So that sheds a little bit of insight into why Ipi is the control arm here. So September 2014 to March 2022 to enroll these 160 so patients, but incredible job, 8 years in the Netherlands. And then just some median numbers here that were pretty cool to look at. Median dose of TIL is 40.9 billion. And that's really impressive when you think of there's like usually 2 expansions that happen ex vivo. So there's the first expansion that gets you over, say, 50 million or, 40, 50 million is a nice place to be when you freeze down after that first expansion. And then you do a rapid expansion that tips you over 1 billion. But they didn't just get over 1 billion, they got to 40.9 billion, so 41 billion. They had a minimum threshold of 5 billion to infuse, so they very easily cleared that. And then the median number of high-dose IL-2 doses, which is relevant because in the Lifileucel study that we described, that Chesney study, I think we talked about the median number was 6, which was a bit surprising. They basically got all their high-dose IL-2 in that study. Here, the median number of doses was 4, so ranging from 0 to 10. So this was that traditional going to 15 doses. I think maybe the Chesney was going to just 6 doses. But anyway, very interesting that they gave so much cells and a good number of IL-2.
Excellent. So the fact check's done.
Yeah, good.